So we have done the CT scans. The CT scan is showing a bicuspid aortic valve with not so much calcium and a low coronary height on the left. And the STS score was 2 and the Euro score was 2. So the summary of case is a 65 years female, severe symptomatic aortic stenosis with low surgical risk, small annulus and bicuspid type 1A valve with non-calcified raphe and no calcium and low-lying left coronary. So how to proceed in this case? So again a discussion where to go with surgical aortic valve replacement or transcatheter aortic valve replacement, where to go with self-expanding valve or balloon expandable valve. So how the TAVR has evolved from high surgical risk to low surgical risk. Initially during the 2010 to 12, the TAVI was his option for the only high risk surgery patient from the partners 1A and 1B trial. So the TAVI became the standard for those who are too sick for surgery or prohibitive risk for surgery. Then the gates were shifted in 2016 and 17. The intermediate risk trials came, that is partner 2 trial and SIR-TAVI trial. So the TAVR was proved non-inferior to SAVR and became preferred age greater than 75 years with intermediate risk. And further going in 2019 and 24, there came the era of the low risk trials, the partner 3 trial. Now the 7 years data was available and evaluate low risk trial. Now the 6 years data was published last week. So the TAVR showed superior or non-inferior to the SAVR. So how the guidelines changed? So the 2021 ESC guidelines, so the TAVR or SAVR decision is based on the surgical risk. So calculate the surgical risk. If the surgical risk is high, go for TAVR. If the surgical risk is low, go for surgical aortic valve replacement. But if you see in the 2025, the whole spectrum was changed. There is no more calculation of the surgical risk. It is only the age of the patient, anatomical suitability and the lifetime management. So the TAVR is recommended in any patient greater than 70 years of age with a tricuspid anatomy, if the anatomy is suitable. If less than 70 years, then SAVR. So the no more concept of low surgical risk, high surgical risk or intermediate surgical risk. It is only the age of the patient and the anatomy of the patient. Next, the next point to address is regarding the timing of the TAVR in the natural history of aortic stenosis. So like the stages of the heart failure, we are also having the stages in the aortic valve disease. If the disease is confined to only the aortic valve, it is called stage 0. If the disease involves any LV dysfunction or left ventricular concentric hypertrophy, or diastolic dysfunction or systolic dysfunction, we call it as stage 1. If the disease spreads to the mitral valve with mitral regurgitation or atrial fibrillation or left atrium, involvement of the left atrium, we call it as stage 2. If there is any incidence of pulmonary hypertension, we call it as stage 3, and if any RV dysfunction, it is stage 4. So why it is important? This slide is not moving, can you just let me? So why it is important? Because as the stage progresses, the morbidity, then mortality increases. Even if the patient is symptomatic or not, whether the patient is having moderate aortic stenosis or severe aortic stenosis, whether we have done any intervention or not, irrespective of that, if the stage progresses, then there is an increased mortality. Then there is increased mortality if the stage progresses. So we have to catch hold of the aortic stenosis in stage 0 or stage 1 to get the better results for any patient going for the valve replacement. So by the time the patient reaches the stage 3 and stage 4, many irreversible changes will take place in the LV and LA. So even if you replace the valve, the reverse remodeling is not that much fast and there will be higher mortality. So many trials are coming, whether we can do the intervention, whether TAVI or SAVI in asymptomatic patient, that is the next question to answer. So in asymptomatic patients, we have now data from 3 or 4 trials. 2 are the surgical trials like the Avatar trial and recovery trial, and with the TAVR we have one trial by name early travel trial. So what does it shows that if you do the TAVR in an asymptomatic patients and compare with the and then compare the again with the medical surveillance, definitely the TAVR the patients who underwent TAVR in asymptomatic patients, they scores better in terms of decrease in hospitalization and even mortality benefit also. Yeah, the first case that we have discussed, so this is I'm discussing how TAVR has evolved, and these are the guidelines. This is I'm showing. So symptomatic severe AS or asymptomatic severe AS, if the grade of the disease progresses, then there is an increase in mortality, irrespective whether the patient underwent intervention or not. So the routine TAVR we are doing in this part where the patient symptoms are developed and there is a decrease in LVF, so which is not showing that much mortality benefit. If you are able to catch the aortic stenosis in either stage 0 or stage 1, and if the patient underwent intervention, then there is more mortality benefit. So there should be a proactive management of patient with suspected aortic stenosis. Whenever you are suspecting aortic stenosis with mean gradient greater than 40, aortic valve area less than 1, then immediately the patient should be streamlined by the heart valve team evaluation. We should get a CT scan of the heart valve and the coronaries, and if necessary, if there is any suspicion of low flow, low gradient aortic stenosis, the patient should undergo the dobutamine stress echo, other biomarkers like BNP, and if require invasive coronary angiogram, and we have to streamline the patient. If the patient is symptomatic severe AS, there should be prompt aortic valve replacement less than 1 month, and asymptomatic severe AS, with current evidence, we can refer the patient for TAVR or SAVR, and if the patient is non-severe AS, we have to follow up a clinical surveillance with echo every 6 months and clinical follow-up every 6 months and echo 1 year. So how the TAVR is showing its expanding indications. So it is not only the treatment for now symptomatic severe AS, it is also the standard of care now asymptomatic severe AS with preserved ejection fraction and no symptoms. And some trials are coming even in the moderate AS also. If the patient is having LV dysfunction, there is a role for TAVR. And aortic regurgitation also, pure aortic regurgitation also, if the patient is having high risk and high risk for surgery and the non-calcified AR, so we are doing TAVR for these patients also. For small annulus, previously surgery is preferred. Now with expanding indications from the small trial, so TAVR is preferred in case of small annulus. The bicuspid aortic valve initially excluded from all the trials in the initial travel trials because of the high mortality and high stroke risk. Now with the latest generation valves, the low risk bicuspid aortic valves with not much root dilatation, not aortopathy, so we are doing the TAVR. So how the guidelines shift? So initially it is based on the surgical risk, now it is based on the life expectancy and anatomy. The TAVR age cutoff previously greater than 75 years we are considering TAVR. Now age cutoff was decreased, greater than 70 years itself we can do. Asymptomatic AS previously waiting policy, now you can do early intervention. Bicuspid aortic valve previously related to contraindication, now we can routinely do the valve. So coming back to our case, she is 65 years, low surgical risk, small aortic annulus, low-lying coronaries. So we have done TAVR in this patient by using a balloon expandable valve with good result. What about TAVI in LV dysfunctions? I will explain this through a case example. Here is a 82 years female, hypertensive, recurrent heart failure episodes. So severe LV dysfunction. You can see dilated left atria, right atria, severe mitral regurgitation, severe tricuspid regurgitation, PAH. So definitely she is a stage 4 disease of the aortic stenosis. So normal coronaries. So symptomatic AS, low flow, low gradient aortic stenosis, the stage 3 cardiac damage. So again, the discussion in this patient whether to go ahead with medical management or surgical valve replacement or TAVI valve replacement. So So intervention definitely is recommended in the symptomatic patient with low flow, low gradient AS with EF less than 40. So what intervention is required? Definitely TAVI is recommended in this patient who is a greater than 70 years of age with tricuspid anatomy if the anatomy is feasible. So these are the CT scan which shows small annulus and borderline coronary heights and OK femoral arteries. So elderly female, severe LV dysfunction, baseline conduction defect, so borderline LCA height. So we have done a self-expandable valve in this patient and LV was completely improved after the intervention. Similarly, the bicuspid aortic valve, which once a contraindication, so it is a bicuspid type 0 with only 2 cusps. In this patient also we have done TAVI by using a self-expandable valve. So coming to the mitral interventions, so again the case example of 65 years female, diabetes, hypertension, class 3 dyspnea, post-CABG, and ECG narrow QRS complex, and these are all the medications, these are telmisartan, metoprolol, and atarvas. So these cases daily we will see as a OPD in a cardiology OPD practice who is practicing since 5 to 10 years, a post-CABG patient or post-PCA patient coming with dyspnea and LV dysfunction and the severe mitral regurgitation. So what next to do this patient? So first we have to assess what is the severity of the MR, is it severe MR or not, what is the EF of this patient, and whether there is any need for coronary revascularization, or if the patient was an optimal medical management or not, we have to see, and is the patient is a candidate for CRD. So after addressing these questions, then we have to think of doing any transcatheter interventions like mitral clip. So these are the criteria for a severe MR. I'm not going to detail. If the jet occupies greater than 50% of the LEA, vena contracta greater than 7, holosystolic flow reversal in the pulmonary vein, and there is a regurgitant fraction is greater than 50%, regurgitant volume greater than 60%, and if EOA greater than 0.4. So assess the severity of the MR and then check whether there is any scope for increase in the medical management, check whether the patient is a candidate for CRT or not. Once all these are done, then we have to think of the transcatheter interventions. So these are the two landmark trials called COAP trial and MITRA FR trial in a patient with secondary MR who are already on medical management by guidelines. So randomized between the mitral clip and the medical management. The mitral clip clearly reduced the heart failure hospitalization in COAP trial, and mitral FF trial there is no difference. So why this? So the secondary MR has different phenotypes like proportionate MR, disproportionate MR, mixed atrial secondary MR and ventricular secondary MR, and the isolated atrial secondary MR. Why to understand this concept? Because if you see the patient with heart failure with reduced ejection fraction, if the MR is disproportionate to the degree of the LV dilatation, like our case example, there will be benefit from the transcatheter H2H repair. If the MR is proportionate to the degree of the LV dilatation, see here the LV is dilated more and the degree of MR is less. These patients, they are not going to do better with the transcatheter H2H repair. Medical management is better for them. So we have to see how to select a patient for this transcatheter H2H repair after knowing the severity of the MR. If the EF is 20 to 50, better. If the LV should not be dilated much, and the functional class should be class 2 and 4, and the pulmonary artery systolic pressure should be less than 70. These are called COAP criteria. Once the patient satisfies this COAP criteria, then they will benefit from the mitral clip. So any heart failure patient with secondary MR, initiate the guideline directed medical therapy and see whether the COAP criteria are satisfied or not. If criteria met, then send for the mitral clip. If not met, then send for the either transcatheter mitral valve replacement or LVAD or heart transplantation. We have some evidence of mitral clip benefit even in patient with moderate MR also. In moderate MR, secondary MR also, if after starting the guideline medical therapy, if the patient is not responding, then we think of the mitral clip. So these are the different clip devices. I'm not going into details of this clip details. So we have the mitral clip, and we have a device called Pascal device, and we have one more device called Dragon clip from the Chinese, and we have some Indian clip also called My Clip, which is coming soon. So these are the guidelines, how they are evolved for the mitral regurgitation mitral clip. In 2021, it is only class 2A indication, but recently this is a class 1 indication. So MitraClip is recommended to reduce hospitalizations and improve quality of life. Any patient with AF less than 50 with severe secondary MR, despite optimal medical management therapy and CRT, then it is a class 1 indications. So if the patient is not suitable for this MitraClip, that means if the patient has severe calcium and there is a high mitral valve stenosis and the leaflet length is not sufficient for grasping by the MitraClip, multiple leaflet jets, perforations and rheumatic stenosis are there, then we have to think of transcatheter mitral valve replacement. There are many devices like Tendine, Intrapid and Evoque valve. So many devices are coming and going, but the 3 or 4 devices which are in currently usage are the Tendine, Intrapid and the Evoque valve. Coming to the last topic, the tricuspid interventions. Previously, it is a neglected valve because the moderate to severe TR is common in patients with advanced heart failure with symptoms and associated with worse survival, but it is a neglected valve. Nobody used to bother about this valve. Much of our concentration is on the left side, the mitral valve and aortic valve, and we have neglected this valve. But now the studies found that the worst survival with moderate to severe TR in any patient with advanced heart failure. So it is profoundly under treatment by the surgery and is only often discovered late in patient with right-sided heart failure. So the TR detection, its quantification, its categorization and risk scoring and intervention is required for appropriate management of this patient. So we have 2 options like the mitral valve intervention. It is the transcatheter edge-to-edge repair of the tricuspid valve. If the repair is not possible, then we can think of the transcatheter tricuspid valve replacement. Recent guidelines also, they have updated from 2B from 2021 to 2A in 2025, the transcatheter edge-to-edge repair of the tricuspid valve. So I will conclude by saying that the choice of intervention for aortic stenosis, that is TAVR or SAVR, is not based on surgical risk scores anymore. It is only the lifetime management of the patient, age of the patient, anatomy of the aortic valve that should be thought during the first intervention. In proactive management of aortic stenosis is required for better triage of asymptomatic patients. So whenever we find a patient with aortic stenosis, even if asymptomatic also, we should get a CT scan done, we should get a surgeon opinion, and we should be ready because most of these patients will develop symptoms in 3 to 6 months, ultimately requiring the aortic valve replacement. If you replace the valve early in the course of the damage of the cardiac disease, the better are the results. The indications for TAVI are expanding. It is not only indicated in severe symptomatic aortic stenosis, but also asymptomatic moderate aortic stenosis, aortic regurgitation, bicuspid aortic valves, and small annulus. The selection of patients for mitral transcatheter edge-to-edge repair is important for better results. We should select a patient with disproportionate MR, meaning the MR should be more than the amount of the LV dilatation to get the better result. And the guidelines recently, the 2025 guidelines has upscaled the MTR from class 2A to class 1 in case of the ventricular secondary MR. The tricuspid valve is no more a neglected valve, so we should catch hold of the tricuspid regurgitation early in the course of the heart failure and we should address. Thank you.
Dr. Ranjit.
Mike.
So the main issue in severe aortic stenosis is we neglect the symptoms of the patient. So patients they tell they are not symptomatic, but most of them will have symptoms in very severe aortic stenosis, and they are very common in our practice. Only thing is that we need to know that if the patient has dyspnea, the survival is 5 years, chest pain 3 years, and syncope is 2 years. So they suddenly die, collapse and die with severe aortic stenosis. So why, though we all know TAVR is there since the last 10 to 12 years in India, but why we are not doing numbers? The one reason is the cost. So when I first did my TAVR, it was 11 years back, it was 25 lakhs. So that was very high for our people. But now thanks to the Indian companies, we have around 8 lakhs, I think the wall now is coming. And it is almost equal to the surgery. So if you take a surgery for an elderly, so 70-year-old, we require a bioplastic wall. Even surgery will cost you 8 lakhs. The wall itself is around 4.5, new walls, good walls. But that is taken care of, the cost is taken care of. The second part is the life of the wall. So as per data, it's only around 8